All right, welcome everyone. Thank you for attending this webinar. Again, this is to kick off the Sikora. So today we're going to talk about histology process improvement. So if any of you have attended any of my other webinars or workshops, that seems to be my theme, histology process improvement. And what we're going to talk about is precision rapid tissue processing. Again, precision rapid tissue processing, anything with histology process improvement, it all centers around changing what you do and incorporating some new methodologies. Lean and Six Sigma. I hope that everyone is aware of these things, but Lean is about that speed, removing wasted time in histology, which we have a lot of opportunity to do. And then Six Sigma is all about your quality, but does also incorporate Lean. I guess the most usable term now is Lean Six Sigma, but what it comes down to when we connect that with precision rapid tissue processing is processes and products. Our product is a slide, eventually a slide, with better quality and faster. We all have that type of pressure that we need to produce the highest quality. Tissue sampling, and that requires and demands standardization. We all have good standardization of our processes from lab to lab, but we're not so good at having that standardization across the whole industry. And I think as we continue to move forward with personalized medicine, new and multiple molecular techniques continue to be pulled back into histology, standardization is going to be key for us. We have to develop and agree process technical standards. Most of you are aware of the difficulties of an H&E stain. We all say we do an H&E stain. As many different labs that are participating today, we probably have that many different H&E stains. We have to get better, reduce the variation. It's a must to have that standardization, because not only do we want to be able to repeat our results in our lab and reproduce them from tech to tech and multiple techs, but we really need to keep pushing for standardization of our processes so we can get that interoperability. That means that if I do a result, create a result, you create a result, anyone creates a result, we don't have to go through the process of recreating that result because the stain is a little different or the processor is a little different. We need to get to that level. So what are we talking about? It's real simple. We need to reduce the variation of our tissue sample size. Just because we have almost 5 millimeter thick tissue cassette doesn't mean we have to have a piece of tissue sample that fills that tissue cassette. My desire would have been that as we developed that tissue cassette, maybe we could have made it a little thinner and we wouldn't have all this discussion now about reducing the tissue sample size. But you're looking at about 2 millimeters or less. We need to adjust, and I mean just adjust, our gross dissection process. Most instances, if you move to standardizing your sample size and reducing it and maintaining a precision thickness of your tissue, you're talking about maybe 30, maybe 40% of your techniques really require concentrated attention and effort to make sure that you have that sample size. We also need to promote a controlled and monitored fixation process. Too often, we just assume that we have a proper fixation protocol. There's a lot of information out there about what the complete fixation is, the minimum amount of time if you're dealing with breast tissue with ASCO-CAP. Now they have two different, depending on whether it's ER/PR, whether it's HER. There's a wide range. I will tell you that 6 hours to 48 or 8 to 72 is not an acceptable range. It's too much variation. You will see a difference between an 8-hour fix and a 72-hour fix. So you need to promote and start developing a controlled and monitored fixation process in your own lab. Improve and increase quality and consistency. We have to. If we make any changes, we have to make sure that we maintain or improve quality and we can increase consistency. And then the main part about doing precision rapid tissue processing is you have to deploy the same precision and standardization as you apply to your IHC staining or your H&E staining. We just kind of throw things into our tissue processors, and then we spend all this time downstream trying to figure out why we have to do all these special techniques to make things work. If we spend more time on precision and standardization at the beginning in our fixation and our processing, you'll have less problems downstream. Again, consistent tissue artifacts from sample to sample. And that's exactly what we do. We produce tissue artifacts for our pathologists. Everything we do creates an artifact in that fresh tissue sample. So you want consistency, sample to sample, tissue type to tissue type, and day to day to day. That creates confidence in your pathologist and in your process, and it does move quality up the ladder. Increase standardization by reducing the variation, cutting smaller samples, whether it's a tissue biopsy, whether it's a piece of uterus, a gallbladder, a colon, a breast. Cutting that and standardizing that and reducing that variation will give you consistent processing results. Increase productivity. Once you get past the processing and you have not created all of these situations with your tissue that either it's overfixed, underfixed, overprocessed, underprocessed, then you will increase your productivity for all your downstream processes, from embedding to microtomy to all your various types of staining. You want increased efficiency at every step after tissue processing, and it is acceptable to do the appropriate amount of time at the grossing bench with fixation and with processing to make sure that you can be very efficient downstream. And of course, you want improved quality. You will get improved quality and customer and employee satisfaction. And that, I think, is not only just a general statement, but many, many labs have proven that when you incorporate these Lean and Six Sigma, you become more precise and reduce down variation in all of your techniques, not just your tissue processing. You get a much better employee satisfaction, and that's very key for us. So, tissue dissection. So what are we talking about? No larger than a nickel. That has always been, besides the PAs, pathologists have been trained to. It's 2.2 millimeter in diameter, 2.2 millimeters thick. Anything smaller is fine, but we don't want to go above. Think of it, whatever process you have. Of course, I've used the Express for many years now, and one of the early adopters. But whether you're using a 1-hour process, a 2-hour process, a 3-hour conventional process, a 5-hour, a 7-hour, think, why are you using that process, say in conventional, for 5 hours, for 7 hours, for 9, even 10 and 12? Why do you need to have that? If you had a more standardized tissue sample, you could gain all that time back into the lab for doing other processes other than tissue processing. And again, if you talk to a lot of your PAs and pathologists, as you see the picture on there, that's their idea of a piece of nickel. It's not a chunk of nickel. We don't want to overstuff cassettes, whether you're doing conventional or rapid processing, and it's very critical for rapid processing. And you want to allow for adequate flow of your solutions through and around your tissue, and it's okay sometimes to use more cassettes. It's not inefficient. Cutting something up and deciding on, such as you only want a certain amount of tissue pieces in a particular cassette and then move to the second cassette. Think of when you get to microtomy, if you jam all those pieces, all the time that somebody spends at microtomy making sure that they get the appropriate and highest quality section, if you move to maybe 2 cassettes or multiple pieces and split that up, they'll be able to cut those easily, more efficient. So adding more cassettes is not always inefficient. So both width and diameter need to be controlled. It's hard to do this by just your eyesight, but in my experience and several other labs that I interact with, somewhere around 70% of your tissues come in, lend themselves readily to cutting to that 2 millimeter or less standard. Always use multiple steps, never stuff. So again, that decision has to be decided, but that can be a very efficient way. And then you want to trim your sections to create clean edges. That helps you in microtomy. It helps you in embedding. Helps you identify what you have to do at embedding and microtomy to make sure you get full sections and can be as efficient as possible. Well, it helps you reduce down your recuts. You'll have to use some tools to be consistent. And again, we're talking about 30% of the time you'll use some tools. There are multiple vendors out there dissecting forks or tools. Precision forks, which we'll discuss a little bit later, I think are probably the most accepted. There are cutting boards that have wells for larger pieces of tissue. In my experience and experience of multiple PAs and grossing assistants, the forks are easy to use, and they become a replacement for a forceps. You have to apply when you're reducing down your variation and creating that precision at your grossing bench. You have to apply the appropriate time at the task and to ensure appreciable gains throughout the process. So one of the concerns always is that if you spend more time, we're not going to be able to get this all grossed. Well, think about it. Think about how much time your certified PA, your grossing assistant, or your pathologist is actually spending at the grossing bench. Adding a little bit more time does not normally mean that you're not going to be able to complete your samples for the day. And as this process of creating precision at the gross dissection bench becomes trained and ingrained into your protocols and procedures and with your individuals, they'll become much more efficient. And again, trained standards for certified PA, it's already there, cutting to this nickel size. We just have to demand compliance, that it's not acceptable not to hit this precise small variation sample size. So here are a couple of things from Sakura. On the left are the forks. They come in different thicknesses from 1.5 to 2.5. Those are surgical steel. They're easily to put into the tissue. You make your cut with your scalpel around that, and now you have a clean, precise sample to place in your tissue cassette. The boards on the right, this is the well, which seems to be real popular. You set the depth of the well, and then you're able to put larger pieces of tissue, hold those down with the dampers, and then slice that with your scalpel. But again, precise tools so that you can create precision. You've got to use tools to assist. You can't eyeball. You know, I've worked with a lot of different people where they say the eyeball, and then you get something from 3 millimeters down to 1 millimeter. Again, that's going to give you inconsistent process. Think of it. You have a piece of uterus or a piece of colon where at one end it's 3+ millimeters, at the other end it's 1 millimeter. Well, you put it into your processor, whatever your processor is, and again, this is very critical when you move to rapid tissue processing. Put in your processor, well, now you have a piece of tissue that is probably going to be closer to being over-processed on the 1 millimeter to not adequately processed on the 3 millimeter, just in that one tissue sample. Think of the variation that you're giving to your pathologist. So size of sample is critical. Appropriate processed tissue, never over-processed. That's why, again, rapid tissue processing. If you can complete exchange and into paraffin in 1 hour or 2 hours, why use 3, 4, 5, 7, or 9? Appropriately process your tissue. Again, you'll reduce down your variation. So here's an example of using the forks, and we'll get to the boards. It's simple of putting in the fork, and again, the PA, the grossing assistant, the pathologist, this becomes interchangeable with your forceps. Slice on both sides on the end, and you'll take the sample out from in between the forks. That is the sample you have. Here's an example of the grossing wells when you have a larger piece of tissue. You're able to hold it in place, cut it through with either a larger blade or your standard scalpel blade, and it'll give you a very consistent thickness and size of tissue. Again, we're just asking for a little adjustment at the gross dissection. Spend a little more time, be more precise, everything else gets better for you. So forks and boards, when you start asking in the grossing room for people to start using the forks and boards, it is a new technique, and it has a standard learning curve. If you have more than one person, you're going to have different learning curves. We've trained 18+ PAs and grossing assistants to date. Initially, there's always a dip in productivity, and that happens whether it's with your PA, with your histotech, with anybody in your process. If you introduce a new technique, you're going to see a little bit of a dip until they become comfortable, proficient, and hopefully then move to competent in that. Your final productivity can be as much as 15 to 25%, because when you start using the forks appropriately, you can more quickly, even with your precision, more quickly gross dissect certain tissues. Here's an example, and on this example, the bottom in the black are resection tissues. They can move, take a dip. A variety of people took a dip, then everybody moved into a very consistent pattern once they started using. Think of a colon. The process of opening up the colon, the rinsing the colon, to maybe you pin and fix the colon, then you come back to that colon. Think of all the time that's used there. Now, think of the possibility of opening up a colon resection, rinsing, and without fixation, you get to see the discolorization, the changes in colorization, the change in tissue. You can place that fork wherever you want to take that sample and quickly take that and get a very precise sample with little variation without having that long process. Certainly you'll go back and fix the rest of that tissue, and you'll fix that sample before you move it on, but it allows you to have a different perspective for samples like that. And on the top, in the blue, these are more of what we will call the small biopsy diagnostic tissues, that there's a dip, and then eventually everybody moved up into a higher rate of productivity, all becoming comfortable with the process and the new tools that you're going to be using. And I would think that in most labs you'll see a similar type of learning process. Now that we've got to standardization, you're getting tissues in. If you're in a hospital situation, you're probably getting tissues in fresh, and that is a trend that's happening across multiple hospitals. The surgical departments, the other departments don't want the formalin, so they're delivering fresh. So you're going to get fresh tissues. You're going to, if you have departments that do put in the formalin, you've got a variety of samples in fixative. So with your tissue fixation, most often it's formalin fixation. That is what we're all trained to work with. That's what the pathologists are trained to look at artifacts. So we're going to continue to work with and use formalin for our fixation for our routine and general surgical pathology. But the question is, when you start to clock on your fixation time, are you controlling and having your departments or your clients simply stamp when they place tissue into your fixative? And we don't need, when you start controlling this process, you don't need it down to seconds and minutes, but you do need to know if it was in there for an hour or 2 hours. Even more important now, as we move forward with our newer techniques and our advanced techniques, such with the breast, you want to know how long did it take them from excision to getting it into fixative. And if you're looking at ASCO CAP guidelines, you're only allowed 1 hour from that time before you now have an invalid sample, or at least you have to show that you are controlling that time from when it's been excised to when it goes into the fixative. And if it is longer than that 1 hour, you're supposed to be putting a note into your report. And then you also have to look at and consider, how do you segregate your tissue cases and your types? Different types of tissue and different samples require different fixation times. And again, we're talking about fixation times. So how long do you really fix your tissue? And that's a real general and broad term, which is fixed. So, and how long does tissue samples need to be fixed? Now here's the controversial part. You've seen the papers, oh, it needs to be 8 hours, it needs to be 12 hours, it needs to be 24 hours. But what are you actually accomplishing? Are you needing to accomplish complete cross-linking, or are you looking at stabilization of your artifact? Fixation time. Tissues, when you segregate by size, small diagnostic biopsies are 2 millimeters or less. Needle cores 2 to 3 millimeters thick, and that's usually dependent upon the service. They can be even smaller, your needle cores, skin, and then tissue resection. But if you look at maybe trying to segregate those four different types, I think you can better control the fixation, the processing, and the gross dissection. You need to know when fixative is applied to your tissue. And you have to demand the volume of fixative on your small diagnostic samples and even your largers is at least 20 times the tissue volume. That's hard to do on your larger specimen, so you will start maintaining and controlling your fixation after you do a resection of that unfixed tissue. But you will need, and it's important how you're moving forward to look at segregating your tissue types. Fixation time. So here's the controversial part, 4 to 6 hours. A lot of samples go through. So you're really looking at, what I think we're looking at is diffusion rate of formalin. Is it getting through and diffusing into the and stabilizing your tissue? So basically, you're looking at antifreeze moving through your tissue when we look at a buffered formalin. If you use an average rate, and there are different types of rate, and the precision, again, how precise, but we use an average rate of 0.7 millimeters per hour. We allow immersion and fixative a minimum of 4 times diffusion rate. Biopsy specimens, the fixation starts at immersion and fixative, and that can be given to you by the service or the client. Simple stamp, give them a stamp, say what time to just stick it into the formalin. Dissected sections, if they aren't in, if they're more than 5 centimeters. And that's pretty much what ASCO-CAP says also. If it's more than 5 centimeters, we don't start, and you shouldn't start a fixation time until after you dissect and put into the tissue cassette. Then you need to fix adequately before you move on to any other processing. So fresh formalin solution, you need to also change 2 times. I think it's important that you make sure that you have a fresh solution and that you do not use an old solution that has a lot of blood and particles from that. Use your formalin correctly, at least 2 times, and rotate your cassettes through that. Again, fixation, the cross-linking does not have to be complete to provide a diagnostic section. If you look at ASCO-CAP, what's the minimum for your breast? Is 6 hours. It's more about being precise and keeping the hours with small variation and making sure that you get everything in the same amount of fixation and consistently. You got to have your tissue completely infiltrated and stabilized. I think that's the key part. And I've worked with University of Miami and Dr. Vernon and Dr. Morales on this about what we're actually trying to do. What we're trying to do is give a consistent artifact. Now, we see no appreciable change in that 4 to 12 hours. There is some change when you look at small diagnostics from 4 to 6 to 8, and definitely when you get into 24 hours. There is a change. It's not going to prevent the diagnosis with that sample, but there will be subtle changes in there. Again, you want to create consistency. So you follow all your breast guidelines and protocols for compliance reasons. You never shorten that up, but when you have other tissues, you can look at and create different fixation protocols. We're back to the fixation 4 to 6 hours. Tissues need to be completely infiltrated before you introduce them in alcohol. Now, if you don't get that infiltration or that, quote, fixation, and you put it in alcohol, your tissue samples aren't non-diagnostic. They're just alcohol fixed, which is more of a coagulant, and it's going to be a different artifact. You think about cytology samples. Most cytology samples are all alcohol fixed. So, and that's very diagnostic, and that's all the way down to the individual cell that you're reviewing. So alcohol, formalin are both acceptable fixes. They just give different artifacts. Once your tissue is stabilized, your histology really doesn't change. So if you get that good stabilization with your formalin fixation, now you can move to other alcoholic solutions, and you're not going to see that histology change. All tissue types work with this process, whether it's a complex resected tissue or whether it's a more simple, small diagnostic biopsy. And those can get down to 0.1, 0.2. Tissue fixation time is 4 times your diffusion rate. It's okay to extend your fixation time. You may see a little variation in what the pathologist will see on their stained slides, but you never want to shorten once you come to what your minimum fixation time is. You have to make sure that everything is there. And you want to, I think, and as I'm saying here, you want to reduce that variation to within a couple of hours. I think you'll have better performance and more consistent performance day to day, tissue to tissue. So again, we're talking about your fixation. And you have to remember that tissue in a fixative solution, whether it's formalin, alcohol, diffusion rate is half the time for the thickness. Because you're coming from all, from all sides and from all directions. So if you have a 2 millimeter thick piece of tissue, you're only talking about, to get this infiltrated and diffused in 1 millimeter because you're coming from all directions. So you actually are getting adequate fixation, and you have more than enough time for everything to stabilize. Now, when we start moving to a 5-millimeter thick piece of tissue that's shoved into a cassette, well, you've got a diffusion rate for 2.5 millimeters, and at least 4 times that. And as you get thicker, you will start getting slower diffusion rates. So it's critical that you have that standardized piece of tissue. It's small enough, but still adequate for your complete techniques, protocols, and diagnosis. So with tissue fixation, you have to follow all your guidelines for breast tissue. If you don't follow those guidelines, you aren't going to remain compliant. So make sure that you have those set and you make sure that you're following them. Remember, fixation time requires complete infiltration. Is it best, that's what you have to decide, is it best that you go complete cross-linking, or are you really looking at stabilizing the tissue? And I think completely infiltrated tissue is stabilized, and that's what we're trying to do. We're trying to create a stabilized and consistent artifact. Histology is diagnostic at minimum times. Typically, most of our biopsies are at 4 millimeters. We often, and you will often get requests for staph biopsies, and maybe they have a little bit more alcohol fixation, but they're still diagnostic. Now, when you have certain FDA protocols, you must always follow those guidelines. You want to complete your fixation before moving to any pre-processing, whatever that is, whether you're moving into alcohols, but that's your next pre-processing. And you never want to shorten your fixation time. You have to stick with that 4 times the diffusion rate. When you move into pre-processing, and when we talk about rapid tissue processing, you're talking about a processor, such as the Express, that has no fixative on the processor. If you have a conventional fixative processor and you have your first 2 stations are fixative, I would suggest ask yourself why. Why aren't you controlling your fixation and taking that off there? Your tissue processing will be even more efficient if you take the fixation step off. The tissue processor is a tissue processor, not a fixer processor. We've kind of tried over the years to combine those two. So after you do your fixation in formalin and you've controlled that and you've had a couple of changes and you have adequate infiltration, you're ready to move on, you've got to remove all that formalin, blood, lipids prior to putting that on your tissue processor. Again, whether it's rapid or whether it's conventional, this will help you get more consistent results. You want to extract your impurities. You want to start the dehydration. You always want to have at least a 2x change solution, rotating. That can be done with your automated processor. That can be done by hand, whichever works out. You want to, I think, that you have to get down to, for this precision, you have to get down to changing your solutions by cassette count, and that also means cassette count and by tissue type, because you just can't say I'm going to do this once a day, twice a day. You have to be more precise. You have to get down to cassette count. And you don't want to exceed 30 minutes, especially if you have this standardized small variation tissue. What do you need more than 30 minutes to start this processing? You want to place your tissue in a stabilizing solution to allow for organizing of your cassettes. Now, that stabilizing solution can be a couple different things. If you're doing more resections and you're putting a fresh piece of tissue, you're holding that tissue section in formalin until it gets its adequate and precise amount of fixation time. That can also be stabilizing solution. If not, then you're moving to something that is less harsh, probably a graded type of alcohol or a pre-processing solution. And this will also help you whether you're doing rapid or conventional. It's going to extend the reagent use on your tissue processor. Think if you extract a lot of those impurities and blood and lipids before you ever get on your processor, you'll get a better performance and get better use out of your reagents. So it's about maybe creating a little bit more of a step process. Again, we're removing the blood and lipid and formalin from there, and that just, again, you got to have that 2 times solution rotation. Here's an example of a tissue pre-processing protocol. Everybody will develop their own. This goes with the Express. There are standard protocols and extended protocols, 1 hour, 2 hour. Whether you have your biopsy protocol or your routine protocol, if you move into precision tissue sampling and fixation, you can reduce down those conventional. Again, if you're going to go all the way to precision tissue sampling, I say move to rapid tissue processing and gain all that time back that you're having your tissue sit on a processor into your histology department so you can work with the tissue better. So this is just an example. So when we kind of summarize for rapid tissue processing, you want to standardize the process. It demands. I mean, too long, we've just kind of waited until we get to microtomy before we start standardizing. You want to standardize the size, and you want to standardize your fixation protocol. You've got to standardize the size of your tissue sample, you've got to use grossing tools. If not, you will have too much variation. And I will tell you, I think the amount of variation we have at the grossing bench is really unacceptable. We've got to get real precise. As we move into more molecular techniques, precision, precision, precision is what we have to have. So we need to move that precision to our routine surgical pathology. You want to complete your formalin infiltration before moving to any alcohols. You want to make sure that your tissues are stabilized and that you don't affect the change in the histology artifact. Standardizing your tissue sample and fixation time does create precision. The goal is thickness of the tissue sample 2 to 3 millimeters or smaller. And probably I'm going to say, I give some leeway to 2 to 3. I'm going to say your goal is 2 millimeters or less. All tissues can be grossed to this specification. There isn't a tissue sample that you cannot gross to the 2 millimeter or less specification. Maybe it takes a little bit more time, maybe it takes a little bit more effort, but again, that gains you hours as you move through the rest of your process, whether it's you're taking it off of your tissue processing or how you're cutting, the consistency and the efficiency that you gain. All tissues can be rapid processed. Now remember that if you move away from any FDA-created protocol, you must do a validation study to show that you can produce the same results, but all tissues can be rapid processed. I think that's been proven for years now, and it is something that you should look at so that you gain more time into your histology. Use rapid processing, no need to over-process it. The term I use, if you happen to be a lab that has one conventional processor and everything goes on to it at the end of the night, end of the evening, and then we take it all off at the next day, and that's a pretty common process for doing tissue processing. It's kind of like Goldilocks and the Three Bears processing. You have some that are a little over-processed, some that are a little under-processed, and some that are just right. Can that really be acceptable as we move to personalized medicine, molecular techniques, and the demand for increased quality and consistency in the pathology lab? So there's never a need to overprocess. You want to adequately process. And if you have a 2 millimeter or less sample, you can do that in 1 to 2 hours. And then always remember the nickel size, not the chunk, but the size of the nickel. That's really what your goal is. Maybe you want to place a nickel on the grossing board to remind everybody, but to be consistent with the nickel size, you're going to have to use some sort of grossing tools. Just what we're going to have now is just a couple examples, and I didn't take out a lot, and it's always difficult when you put these into PowerPoints and depending on how the pictures are taken. But this is just a express process gastric biopsy where the arrows are. We're looking for H. pylori. It's a common thing that we do. But, you know, this is a 20X. You can use any and all kinds of diagnostic tissue. You can also use and perform on rapid processed any and all types of your IHC. This happens to be an IHC for H. pylori. No effect at all for using standardized tissue samples, fixation, and rapid processing. You get a very good result and consistent result. This is a piece of breast for invasive carcinoma, H&E, processed on the Express. Very diagnostic, and again, because we have so much variation in the H&Es, this is just, again, a small example of what you can do with rapid, precision rapid tissue processing. ER sample from, again, a breast invasive carcinoma Express process. Very consistent, very crisp, very clean. That crisp and clean is always debatable, but it is very consistent diagnostic tissue. HER2 on the same breast type of breast sample. As you can see, again, by creating precision, you can create consistency. And again, we can't don't have the time to go over many samples, but you can get very good diagnostic, reliable, and consistent results using precision rapid tissue processing. Piece of cervical cone tissue, KI67, and then that's the end of the photomicro SNA. So again, before we talk about or Alicia talks about the Express, we're talking about creating precision, and think of it, creating precision at the beginning of your process makes everything else more efficient and more proficient. Go ahead.
Thank you, Bill. I do appreciate your time in presenting a wonderful webinar today on precision rapid tissue processing. At this time, I would like to ask the audience if they have any questions to please type them into the question box, and we'll go ahead and ask Bill those. In the meantime, since this presentation was on rapid tissue processing, I would just like to show two of our instruments that are rapid tissue processors. They are also continuous flow processors, and they are our TissueTech Express X series. We have an X50 as well as an X120. Both are based on the same technology. These instruments do promote standardization. You no longer have to batch your specimens. Your biopsies along with your routine tissue can be processed together in the same run. If you're using the X50, you can process in an hour and a half, or on the X120, you can get processing done in an hour. These two processors, you can find more information on our website, or you can always contact your local Sakura rep. Bill, I do have some questions for you, so I'm going to go ahead and get started. One of the questions is pertaining to our grossing tools, and it says, if you purchase these tools and they are still not being used, no PAs or HTs do the grossing at the location. Do you have any suggestions for compliance?
Well, if you're not, so I guess what you're saying is that none of their PAs are willing to use the tools. I mean, depends on what kind of management authority you have over the process. If the PAs that are actually managed by your pathologist, you must, as with any change process, you're going to have to get buy-in from the pathologist. If they are your own employees, then you have to demand compliance, and there are a variety of ways that you can demand that compliance. Before you get into the demand part, I would suggest that you sit down and you discuss why you're needing to do this, what your outcomes can be. And again, most often this is going to take participation by pathologists. I have found, and consistently pathologists are very interested in high quality, consistent, day-to-day results, and the tools are just a mechanism to help you gain that. I just don't have any magical suggestion or term, but it does require that whoever is in charge of managing, that you demand compliance from those individuals, just as you would if you have supervisory authority over your histotech. If you wouldn't allow them to use a nicked or a dull blade to cut tissue sections, you demand that they use the appropriate tool. So that's how you have to move forward with that. Next question, Alicia.
What is your recommendation for reprocessing tissue samples?
Well, my recommendation is that you spend time up front in your process, and you'll have less opportunity or need to reprocess. I'll give you my experience with the Express and reprocessing. Again, the Express only has an alcoholic formula and paraffin on it. You remove your paraffin, and there are a variety of ways, but you want to remove your paraffin, and you only want to take it back as far as you need to in your process. There isn't really a good accepted protocol for reprocessing tissue. One of the things that we have found is that if we happen to have somebody put in something thick and we do not get it accurately processed, one technique that we're using is that we let that tissue come to room temperature in the paraffin as much as can, and then have a PA trim that paraffin tissue before we move it backwards into removing paraffin, then moving it to alcohol, and then moving it forward again. So typically you just want to use xylene and your alcohol and then move it forward. The problem is, depending on what the tissue was and what the cause of your underprocessing, you do take the risk of not having a diagnostic piece of tissue. So with the risk of having a sample is no longer diagnostic, and it may be that one, maybe it should be an irreplaceable tissue sample. Spend more time making sure that you have thin, consistent tissue samples and accurately fixed before you ever move to processing. Go ahead.
Thank you. The question states, you said all tissues can be rapidly processed. Does that mean I can put a nickel-sized piece of lymphoma to be processed to your specifications and it will be perfectly fine?
Ooh, that perfectly fine is a very wide variety. But if you cut that lymph tissue at 2 millimeters or less, and you adequately fix, properly pre-process, and put it on probably, my experience would be with the Express would be the 2-hour run, you will have a very diagnostic piece of tissue. I can't guarantee, or no one can really guarantee whether that is the expectation of your pathologist. This is a process that you would have to work through with your pathologist, because right now, whatever processing protocol you're using, your pathologists are used to and like that artifact. So before you change to rapid processing, before you change to any change in solution in your protocols, you need to have that discussion with your pathologist. But I am very, very confident that cutting to that 2 millimeters or less, properly fixating and controlling that fixation, and using a 2-hour Express process, yes, you will have a completely fixed, processed diagnostic piece of tissue.
Thank you. The next question is, isn't it true that the reagents are proprietary?
Well, both of us can answer that. Yes. I will tell you that the reagent pack, and I am a user of the Express 120, is a proprietary pack. So if you're using a conventional processor, how many gallons do you use? For 900 plus resection specimens or cassettes, or 1,200 plus biopsy cassettes, I use 2 gallons of a proprietary solution. That was over a 60% saving in volume of solution from moving from conventional to rapid processing. It depends on what you're paying for these solutions, but we did see an appreciable drop in cost of reagent, and more importantly, the big savings in cost for us was removal of those hazardous solutions, which everything in my location and my experience here is that everything but water has to be barreled and taken out by a hazardous waste hauler. So reducing from 6-point-something gallons on a conventional processor to 2 is a big savings. You will have to do that calculation yourself, and I do. You should calculate and incorporate into that calculation the amount of fluids and your disposal of your fluids. Amount of fluids used and the disposal of your fluids. I have not seen an adverse effect of using a proprietary reagent pack on the Express.
Thank you, Bill. The next question is, what is the stabilizing reagent you mentioned?
The stabilizing reagent, and again, it's kind of hard. If you're using resection tissues, your stabilizing holding reagent is typically your formalin, so that you get adequate fixation. If you have small biopsies, I suggest a more of a molecular-friendly fixative, so that you stop the formalin fixation and move it into more of an alcoholic fixative. Straight alcohol, isopropyl alcohols can be a little harsh, so we'll typically, if it's a small biopsy and it's been completed in its fixation time, then it's a molecular fixative, a little bit less harsh on the tissue. We tend to get better performance on it. You can use graded alcohols, but your stabilizing or holding solution, if it's past your fixation time, is you want to stop the formalin. So you want to start removing that, so it would be an alcoholic type of solution. If it is a resection, a lot of times your stabilizing or holding solution will be your formalin fixation, because those larger specimens that started their fixation process at the time you went into the cassette would be holding into your formalin, waiting for adequate fixation before you move it into your rapid processing. And again, the key part for rapid processing, if you use something like the Express 50 or what we use the 120, is that for me on the 120, if you're using a standard, every 20 seconds you can add any from 1 to 40 cassettes, so nothing waits around for the processor. So it is very useful that you have precision fixation and pre-processing protocols. So I hope that answers the question.
Thank you, Bill. The next question states, nice micrographs. Besides IHC, what other molecular techniques are you performing in your lab that require rapid processing?
Well, there are other molecular probes. We do ISH and FISH, and then we have regular probes. You typically, on those samples, those are not going to be formalin fixed. They're going to be fresh samples moved right to a molecular. Here's another advantage of using the Express. There is no formalin. There is no other solution on the Express. It is a proprietary reagent, but it's an alcohol. So you can put and process, if you adequately pre-process your formalin-fixed tissues with your molecular, you can both put those and run those at will on the Express. So ISH, CISH, and then standard molecular probes for, say, KRAS is a normal one. You're using a molecular fixed tissue that is then processed to paraffin. No formalin fixation, just molecular fixed, and it goes on to the Express and processed to paraffin. Imagine this can work with a variety of IHC platforms. We have to use Ventana.
Okay, thank you. The next question is, standardizing an H&E stain is something our lab is going to be looking into this year. I'm leaning towards the Symphony from the Ventana. Do you have any recommendations?
Well, it depends on what you're going to do to standardize. My suggestion, since you're attending this webinar, is before you look to standardize your staining protocols, I think you'll have much better performance out of your H&E stains if you back up and first standardize your fixation and your processing and tissue sampling. Again, think of it, if you have something from a biopsy to a 5 millimeter thick piece of Uterus and trying to standardize to that H&E stain, how difficult that's going to be. There are a variety of instruments out there that allow you to improve quality, reduce variation, and give you good consistency. I think what you choose in your laboratory is a bigger discussion, and it has to come with the pathologist. As you go to instruments such as whether we're talking a processor or whether we're talking a stainer, you have to look at what the options are for adjusting times and volumes, and especially when we're talking about the H&E stainers. With the Symphony, it is a proprietary reagent. It has a very narrow variation in the protocol, and it is one method of moving and standardizing that H&E. If you have a large variation in the type of samples from fixation and processing, I think you'll have more difficulty, just as you would with a Prisma, a Leica what we call the dip and dunk. So it's a bigger question. I really don't have a suggestion for which one will work better, because we have so much variation in our lab that really is still pretty much a lab-to-lab dependent decision.
Thank you, Bill. Once adequately fixed, can all tissue samples, routine and biopsies, be processed in 1 or 1.5 hours? That's an easy one. If cut at 2 millimeters.
I can tell you, if you're 2 millimeters or less, you can process on what I have available to me in the standardized protocol. We typically do most of our resection tissues in the extended, because much as we try and demand compliance, I do get some variation from PA to PA on their resection samples. So we tend to use the extended, which is the 2 hour. I believe it's actually from start to finish, it's like 2 hours and 20 minutes. And the standard is 1 hour and about closer to 1 hour and 10 minutes from start to finish. Yes, you standardize at 2 millimeters or less, you can put resection and biopsy tissues together, and you will get an adequately and properly fixed paraffin infiltrated specimen.
Thank you. I have about 2 more questions. And the first question is, considering a rapid processor for a research lab, what recommendations do you have for rapid processing of small animal tissues?
Well, animal tissues are always a little different than human tissues. They have different protein makeups, and they typically, when you look at those for using conventional processors, they will have entirely different protocols. Again, if you're talking about a research project or protocols, again, you're going to have to look at what you want to achieve. I personally would say that if you use a processor that has minimal amount of effect of reagents and time on the tissue, then you can more properly control those research samples for the particular type of fixative and what your treatments are going to be to those samples. That is going to be even more critical in a research project. Again, even with animal tissues, you will have to cut to a standard and maintain that standard for precision, and you should be able to also do that in rapid processing. It will take some trial and sample. I don't work with a lot of tissue samples. I have in the past, but I haven't worked with a lot of, because I'm working with human, I haven't worked with a lot of animal tissue samples on the Express. But I would be very confident that there is a thickness specification, and then you would have to do some trial and error for whether you either do a 1 or the 2 hour. And my guess would be, early guess, it's going to be 2 millimeters or less. You may have to go a little thinner for animal tissue, and you would probably want to run in an extended protocol, which is the 2 hour protocol, just to give your solutions a little more time to work through those different complexities of tissues when you move to animal.
Thank you, Bill. And just to follow up on that question, the specifications for grossing are exactly the same whether it's animal tissue or it's human tissue. So using the standard processing protocol, no larger than 2 millimeter sections. Using the extended protocol, no larger than 3 millimeter sections. And our final question for today is, what solution do you use to extract impurities? Low-grade alcohol? If so, what percentage?
It's an isopropyl alcohol mix, and I happen to use also a proprietary solution from Sakura. It's a pre-processing solution. And I will say it's, correct me if Alicia, its majority is an isopropyl alcohol in there. But using pre-processing, all alcohols will start to extract those lipids and impurities. And again, it's a matter of multiple changes and how rapid you want to do that pre-processing. But we have chosen to use the pre-processing solution, PSS, I believe is how it's supposed to go.
PPS.
PPS, I'm sorry, pre-processing,
yes.
PPS.
Correct. Yes.
But it is mainly an isopropyl solution.
Thank you. That's about the amount of time we have for today's questions and answers. If we did not get to your question, I believe Bill's email address is at the beginning of the presentation, or you can send that directly to me and I can forward them on to Bill. Once again, I'm sorry.
I didn't put the email on the front. I don't.
Oh, I'm sorry. Okay, then I'm sorry. Send those questions to myself and I can forward them to Bill for answering. The link to download today's presentation is located on the original email that contained the login information. So if you scroll down to that email, after the login information, there was going to be a link that says today's PowerPoint presentation is available. Click on this link below. So all you would have to do is click on that link. The PowerPoint will come up and you'll be able to save it and or print it. Thank you once again for your time today. Thank you, Bill, for a great presentation. I hope everybody enjoyed it and will be joining us next month for Understanding Fixation. Everybody have a great day.